going on with the most important, because I think I can see that there are some of the participants who are all physicians also, or some are like practicing doctors. So I would like to just share the most recent type of protocol or the most recent type of management, and which is being published by our cardiac societies, especially the NICE guidelines or the AHA guidelines, because they make us simple in form of assessing as well as the diagnosing as well as the part of the treatment. So the most important, the first one, what comes to in our mind whenever there is a chest pain, and this is something important. Like any pain, anywhere else in the pain can be neglected. But if a patient has got a chest pain by any reason, let it be an acute peptic disorder, let it be a gastric acidity, whatever is it, am I having a heart attack? Is it a heart attack? And the same question fits for the examiner, that is the doctor or the emergency physician. Even he's whenever the patient comes with just chest on it, is it a heart attack? Am I dealing with a patient whether this is a heart attack or not? Whether there is some artery stenosis, whether this patient requires a thrombolysis, whether this patient requires a percutaneous intervention, or no. Whether am I doing it right? This is wrong. Yes. This is the most common thing what we encounter. So, and at the same time, like beforehand, I'm just going to tell you that every second is a myocardium. A second lost is the myocardium lost. Now, so we need to understand certain basic principles of this myocardial ischemia, infarction, unstable angina, and what are the ST elevations in ECG, and what are these ST depressions, or all these symptoms. Does this require a proper diagnosis, or can it be diagnosis, or can it be diagnosed on the emergency basis in an emergency room within some minutes, or do we really require an like specialized or some sort of investigations that may require for hours together? Do we really need that? Yes, sometimes we can. They all help us, but remember one thing, as the saying goes, history. Listen to the patient history. He is telling you the diagnosis. So the history is more important in the case of a chest pain. Now, like let's have this. I think this is well known to everyone. I'm sorry, I have forgotten this. Uh, yeah, this one. So as we know that this ischemia, infarction, or whatever we talk about, unstable angina, we have an angina pain. Like the patient typically comes to an emergency room. Now he has got some heaviness on the chest. Is this pain radiating? Is this pain like associated with some sweating like? Is this pain associated with some shortness of breath? Is this pain very severe? Is the pain can be controlled, or whether it is bearable or not? So all these questions has to be evaluated by the patient, but many times the patient may not be able to give you that much time to have an interaction with you at the same time. The most easiest and the common and the cheapest available tool now is the ECG. Well, an ECG need to be read perfectly for a perfect diagnosis at the same time. Well, we need to have an ECG done. For an every chest pain, I do personally recommend, yes, an ECG has to be taken. The point number one, it's very easily, it gives a lot of information at the same time. Now, what does an ECG talks about? Does a simple reading of an ECG tells you about like the complete diagnosis, or still do we have a doubt? Yes. For this, we need to understand some of these pathological principles. Like how does it going to be? So like for example, as we know, as we all are doctors, we have been practicing, we know that there is some way or the other there is a narrowing of the arteries, either by the atheroma, which has got a cap over it, which is a hard cap, or a thin cap. Well, apart from that, there can be something called as a thrombus, which gets formed instantaneously, that causes an acute myocardial infarction. But before this, in the case of an ECG, that when you are able to read an ECG, make sure that you are going to localize, or you are going to segment out that which particular area we are dealing with. Suppose we see some changes I would like to say, I will talk here regarding the changes in the ECG first. Like we have changes in lead 2, 3, and AVF. This points out towards the inferior wall, right? And whereas 1 AVL and anywhere from V1 to V6, that usually points out to the left descending artery segment. So 1 and AVL and V1 to V2 is the anterior, V4 is the septal, V3, V4 is the septal, V5, V6 is the lateral. So anywhere occlusion, and this is the segment which has been given to this particular heart, this walls and so. So the inferior wall, the anterior, and the septum we know. But you have some changes. You are doubt whether there is changes or not. And it's your luck that you found out some changes in it. Now, next, how to approach. Whether this is an infarction or an ischemia, whether you want to thrombolize this patient or do you want to just go on with heparin and some antiplatelets. Yes. So what do you mean by an infarction? An infarction is nothing but a total occlusion of a coronary artery to a particular segment, then followed by this total blood supply is cut off. As a result, what is going to happen? There is going to be a dead cell, or sometimes called as a necrosis of a particular muscle of this myocardium gets developed to its distal part of its supply. Now, at the same time, one thing can be of wonder over here, that can a small infraction, can it be neglected? Yeah. If it's very small, tiny vessel gets infarcted, sometimes you will not be able to thrombolize it. Sometimes it's not, it's not seen in the case of an angiogram also. Then does it produces some symptoms? Yeah, it definitely produces symptoms. Yeah, then you have to go for an antiplatelets and some several therapy, which we will be discussing in the further slides. So to understand it better, we should understand that whether this patient has to be thrombolized or whether this patient should be on medical management, whether they should have follow-up, or whether this patient should go for a PCI, that is percutaneous intervention. To understand this, what do you mean by ischemia? Have a look on this ECG. Whenever there is no elevations, there are ST depressions seen in the ECG. In these territorial segments, you say it is an ischemic changes. And whenever there's an elevations, ST segment elevations, you see it is an infraction. These are called as a myocardial infarction. So in the case of myocardial infarction, once again, I would like to add on something like this ST elevation is not only does ST elevation every time means that is an infraction? Does every ST elevation needs a thrombolysis? Yeah, many times they need thrombolysis, but there are certain disorders like an early repolation syndrome of the adults, of the younger individuals, and sometimes the Brugada syndrome. They do have a specific pattern of ST elevations, but it doesn't mean that they need to be thrombolized. But in the case like what I was talking about earlier also, that any specific changes, like in the history, especially when a patient complains of typical chest pain, a typical chest pain, like from 2 to 3 years, a typical Levine sign, there is squeezing or something weight on the heart has kept on the myocardium, and this radiates to the back, and sometimes we see and we just come across the pain, anything from the lower jaw till the umbilicus, or all called as an angina equivalence. Sometimes this pain may be radiating to the ulnar border of the right and left hand both, sometimes to the back also. So this history is much more important when we are talking about infarction, when we see like an ECG and correlating it clinically. Now, with the recent tools, we have got lot more, like we have got a 2D echo. We can assess via 2D echo, two-dimensional echocardiogram. We can assess via three-dimensional echocardiogram, even in the case of an emergency. In an emergency setup in an ER, we have it usually. Apart from this, do we have some any laboratory investigations that can help us out? Yeah. We have got like troponins, we have got like certain cardiac enzymes, we have got like CPKMB, we have got myoglobin, which starts up shoots very early. We have got like troponin INT, which are very sensitive and specific at the same time for a myocardial ischemia. It is regarding myocardial injury, I can tell. Not exactly infraction, it is the myocardial injury. Any injury to the myocardium, which later on develops to the infarcted states, yes, they develop, or there is a rise in troponin I or in troponin T. But this definitely takes some time. It takes some time, like for example, say 4 to 6 hours to get elevated. For this thing, if the patient has got a particular history for some duration, like the patient says that he's having a chest pain since 6 hours, then I think you can directly take him up for this troponin IOT, and then you can follow with some serial patients of this level. Then this definitely confirms the diagnosis. Now, you have diagnosed this patient as an infarction, as a myocardial infarction. Then what next?